They did 2 mitra clips, and after the 2 mitra clips, they thought that there was a leak between the 2 clips, and they did not want to put another clip, and so patient has cystic fibrosis. He needed a lung transplant, and he could not undergo lung transplant because this MR needed to be fixed. So you can see the fluoroscopically they were correct that the clips, if you wanted to put the clip in between the 2, it is a little bit difficult because there is not that much space between the clips. However, the proper diagnosis is important. So if you do the 3D imaging, it is clear that the 2 clips are there, but the prolapsing leaflet shown by the arrows is coming from the lateral side of the 2 clips. It is not in between the 2 clips. So you can see here that it is coming from the lateral side. So 2D and 3D imaging is very different. And this is very important to make a correct diagnosis before you say that the clipping can be done or not. So here we could put a clip just lateral to the other 2 clips in this particular patient. And as you will see with the lateral leaflet insertion, there is very nice imaging showing that there is no mitral regurgitation after the 3rd clip. So if the clip is failing, you need to know why it is failing, and proper imaging is very important. Final result was excellent. So lesson 1 is that you have to have state-of-the-art imaging for this patient. When the clip detaches, so sometimes this happens. So this, as you can see, the clip is detached. And when the clip detaches from one of the leaflets, it is here obviously stuck on the posterior leaflet. So if the clip is stuck on the anterior leaflet, I'm sorry, it was in the anterior leaflet. As you can see, if the clip is detached because the posterior leaflet is still intact, you can many times connect the 2 leaflets next to each other. So this is the study I was referring to, that you have to distinguish between the tear versus slip of the leaflet, and which leaflet is torn. You can identify by measuring the leaflets before and after to say that the clip is slipped or there is a tear. And if there's a tear, it's more difficult to fix. It's slipping, it's easier to fix. That said, when it slips, you have to find the leaflet around where it slips to be able to correct it. So here, we found that it was slipped. So what we did, as you can see on the top, you go and clip the leaflet on one side first. So we go very, very close to the anterior leaflet where the clip is attached, and then put the clip posteriorly in the posterior leaflet. This stabilizes the clip, but as you can see, there is still some mitral regurgitation. So then you can come a little bit further close to the clip and try to correct the problem by putting both clips together. And again, attaching the clips where the leaflet is detached is sometimes tricky, and the clips don't want to close very tight if you catch one piece of the clip itself, because here we are very, very close to the clip in the anterior leaflet. But if you are lucky, you can sometimes save this kind of patients. Gradient is very important. So as I said, we measure the gradient, and postoperatively, patient did well. There was still a 6 millimeter gradient in this particular patient, 4 millimeter gradient. This is another patient. Again, I want to say that these are all referrals, but some of this happens to you. So this is a patient that happened to us, that we put a clip and the clip got detached. So this happened the next day. Actually not the next day, but almost a month later. And the patient actually felt it. He was doing some heavy lifting, 85-year-old guy, but he felt shortness of breath acutely. And here, it appears that the anterior leaflet is shorter than it started. So it looks like that it tore from the anterior leaflet. So in this particular patient, we decided to put the clips on both sides of the torn leaflet, because if the leaflet is torn, there is no way to catch the leaflet. So we put the clips on both sides, I call a sandwich, between the 2. And you can see here that the clip is detached and the other 2 clips are holding the two leaflets. You can be very, very close to the clip or slightly away. In this particular case, the medial clip is a little bit away by design because we are afraid of tearing the leaflet if you pull the leaflet too much. So this is something to keep in mind, that if the leaflet is torn, the tissue is defective, and you don't want to stretch it too much. And these are small clips. As you can see, these are all NT clips rather than XT clips because the leaflet was torn. And patient has excellent outcome. So lesson 2 is stabilize the clip. This is another patient. This is another unfortunate patient. I'm sorry. Can you please click on this one? This is worth seeing. On the left image and then the right image. And if it doesn't play, just escape and restart, yeah, because sometimes the computer runs out of the memory. Yeah, just maximize it. So here, initially, there was no MR, and while we are waiting, MR happens. And this is because the leaflet tore. So the anterior leaflet has now a hole, posterior leaflet has a hole in this particular case. And so this is very unfortunate because we had very good result. And now, as you can see, there is a torn leaflet. This is a challenge. So what do you do about this? So there is a hole, as you can see, just behind the clip. The clip is attached, and behind the clip there is a new hole. And if this happens, it's not an easy solution. Of course, surgery can be performed. But as Raj, I think, also showed one of the cases, is that you can put clip next to it. So we put the clip next to the hole. And so now you have two clips. And in between there is a hole which is circumscribed. So now with the hole that is right in between, you can cross the hole, and now you can put a plug in between the two clips. So when we put the plug, as you can see here, plug stayed and the plug was stable. This is challenging because many times the plug wants to come out. This is a 14 millimeter AVP 2 plug. 16 millimeter. So fairly large plug. There was no MR. And this is the follow-up echo. After a year, the plug is stable and the gradient is about 5 millimeters. So this is something that can be potentially achieved. But again, sometimes you have to send these patients to surgery in this situation. So if you have severe MR after the clip, I think consider more clips. Plug can be helpful if there's a tear, and if this is not possible, then surgery is the best option. Thank you.
So once again, I want to thank the organizers. This has been a wonderful meeting. I'm going to share with you one of our cases that we used using the Jenna valve. So the Jenna valve system, this is what it looks like. Essentially, it's a self-expanding valve. It has these three locators, essentially, that do the job of trapping the leaflets. And, you know, these are porcine leaflets. And if you look at this, the design is such that it actually leads to naturally, you know, the commissures to align the way it is actually designed and deployed. And the coronary access is easy because of the large cells. It's available in 3 different sizes, and, you know, unlike other valves where the sheath is short, the sheath here is very long. It actually goes around the aortic arch all the way up to the sinotubular junction, through which you introduce the delivery system. And through the sizes that are available right now, you can deal with aortic regurgitation patients who have annuli all the way up to 85 millimeters. Now, this has been revised, and in Europe, in fact, in the study also, we've actually gone up to 91, though there are people who have actually pushed the limit, even with somewhat larger annuli. So here is the case. Can we increase the volume, please? And start the case. So,
Hemifield graft at that time. Following that, he also had a stroke and is left with residual speech defects. However, in the months following, he's had recurrent admissions with heart failure due to severe aortic regurgitation, and he's in NYHA class 3. In terms of other medical history, his hypertension and hyperlipidemia, he has sinus rhythm but does have a right bundle branch block. His STS score calculates it low, but given his recent cardiac surgery and his recent stroke, he's clearly a high-risk patient and is very frail. Next. Here's our CT analysis of the valve, which shows an area of 562 millimeters squared of the annulus and a perimeter of 85 millimeters. The LVOT is slightly larger. There's difficulty in measuring the sinuses exactly here because there's been a previous repair here, but the sinuses do seem to be roomy and the STJ is also adequate. His coronary heights are high and not prohibitive. His access is good for transfemoral transcatheter procedures.
Can you please share your thoughts about the echo findings?
Yes, thank you, Raj. So I don't know if everyone can see my echo screen, but here I have displayed the short axis of the aortic valve. So the TEE confirms that it is indeed a tricuspid valve. You could see all three cusps. There's a very wide central AR jet that goes from the non-coronary to the left coronary commissure. So it's pretty wide. And as we go to the long axis of the valve, you could actually appreciate like this very eccentric aortic regurgitation jet with a PISA of about almost 1 centimeter, which would be about more than 0.3. So this is very significant. This is what the valve looks like on 3D. You could appreciate again 3 leaflets on this valve with a very wide central malcoaptation, which is the cause of this regurgitation. I wanted to show you a little bit more about, looking at the descending aorta. You could see just off the bat that the aorta is very pulsatile, and there's a lot of color being mixed. So this is what we see when there is flow reversal, and you could actually confirm that by Doppler. So there's a holodiastolic flow reversal.
So let's tell you now what we are actually doing here.
Show us what you got.
So we'll show you, we took an aortic root injection, all right? So this one was with the pigtail. So this is the coplanar view, and actually if you look at it, you can see the 3 cusps. They seem to be fairly aligned, fairly well aligned. Would you agree with that? And then you can, of course, see torrential aortic regurgitation. Now, the key here is to actually be able to selectively get into these cusps when you release the locators. So we actually took injections. So this is injection into the left cusp with a multipurpose. This is injection into the right coronary cusp with a multipurpose. And now here is the non-coronary cusp. So we were actually, at times it is not possible to get to the left side actually with the multipurpose. So you might have to use multipurpose 2, or occasionally you might have to use an AL1 or AL2 catheter. So I think in this case we are hopeful that when we get to the stage of identifying our locators in individual cusps, we'll be able to do that. So we've got a 18 French sheath here. We've got a 6 French sheath here, which is on the left, which is where the multipurpose catheter is. It's very important when you advance this long sheath to make sure your ACT is actually therapeutic. So we will go ahead now through the using a pigtail catheter across the valve. As you saw, this was not very difficult to do. So we have the extra. Let's go ahead and do the hemodynamics just to show pre and post. All right, so let's.
So Raj, I use an ACT of 300. What are you What are you using?
I think
And the panelists?
I think the protocol mandates ACT more than 275, is that correct? 250. Okay, so the protocol says
Yeah.
it has to be more than 250. In fact, what is our last ACT? 291 is our ACT, so we feel comfortable with that. All right, so if you look at the hemodynamics, you can actually see, right, this clearly reflects aortic regurgitation physiology. Look at the LV and diastolic pressure, it is so high. Look at the diastolic pressure. In fact, the aortic diastolic pressure and LV and diastolic pressure almost meet, right? So there's very little difference there. So clearly this is severe aortic regurgitation. It will be interesting for us to come back and look at these hemodynamics after the procedure. So we are gently advancing this, and this is a very, very nice, lubricious sheath, okay? So it's important though, when you're advancing here, to do this very slowly. So I'm going to do that very slow.
To come slowly with this long sheath that comes all the way to the
This sheath is
STJ.
85 centimeters long, and our goal here is to be, with the old system, they would say at the STJ. With this system, they say 2 millimeters above the STJ. So
This patient had an aortic graft, and we wanted to make
All right.
sure that
Okay,
we are
let's
below
flush
the
this, please.
anastomosis.
So
Otherwise,
this is the
it may be hard.
So the valve is here, and this is the introducer tube, which is on top of this delivery catheter. All right, so the valve is contained there. I don't know if you can see, these are the 3 locators. All right, I don't know if you can see those. These are the 3 locators, and we have to
Yeah, we
be
can see
careful.
it. Thank you. Yeah.
As we are introducing, we are going to actually make sure that they are introduced. I'm going to hold this thing together here and make sure that as we are introducing this, these are not damaged. So of course, this is the delivery catheter, and this is the deflector. Right here is the deflector. This is the controller, which gives us the ability to go forward and backward, and the ability to rotate the valve. This is a safety lock, which is ahead of this release button. So we want to go ahead and align the markers, right? Okay, tell me. Are you happy there? All
we are
right, so
good.
we've aligned the 2 markers, as you saw. And now I'm going to hold the delivery catheter and unsheath the valve. Let's make sure that we are happy here, because once we unsheath it, it's going to be hard. We don't want to come above the anastomosis. We may catch there. So let's just take a picture, and I want to be doubly sure. All right?
So the concept is you're
Are
delivering
we
the valve
absolutely sure?
because it has
All
these
right,
locators through the sheath.
So we are going to go ahead and withdraw the sheath.
And you plan to take this all the way back into the descending, correct?
That is correct. Okay, we will now go ahead and get this valve off the outer curvature. So I'm going to hold this, and we are going to deflect. Okay, so you deflect this away from the outer curve of the aorta by rotating this. You can see that as we are deflecting, it's moving away, but also it's opening up. The locators are opening up a little bit. See what happens if I rotated this a little bit. All right, so I'm rotating this a little bit.
So you can look at the TE,
All right.
Yeah.
right?
Now, I feel
And
comfortable now
you can see where these
coming down.
locators are,
Okay.
and you can rotate.
Say that again. All right. So they want to do this. Let's do the C-arm sweep. Okay.
Yep.
So you can see this. Okay.
Yep.
So from left to right. So you see that the middle marker actually goes towards the left, right? So if you were not using
Right.
TEE, this would give you reassurance that you're doing the right thing, and you're actually in the.
So yes, so you can
the
do
right-
this
the
without
middle
TE
locator
also.
in
And
the
you're
right
looking mainly
corner
at the
of
middle
calcium.
marker
Yes.
for that.
Okay. All right. Is that okay? All right. So inject, please. All right. So I think we do need to come down, right? But it is
Yeah, a little high. I think.
yes. So we are high. So I'm going to advance this further. And see now So did you observe that as we lowered it, the locators actually became wider, right? So that tells us that they are now engaging the
Fell
cusps.
into the cusp. I think they fell into the cusp, the nadir of the cusps.
Okay, so I think, so that's a good sign that these locators have become a little bit wider. Okay, so that's clearly the left. There is no doubt about it, and you can see the depth of this, right? Okay. Now, let's go here. All right, so you can see this. Non, perfect, right? So the left and the non are excellent.
Yeah.
Now let's go to the, okay, so I feel we are good here. But, so we are going to do rapid pacing. Huh? Yeah. And we are going to, of course, bring our multi-purpose back, which is a ritual, so that we are not trapped. Okay. So at this point, we are going to, okay. We're going to remove the safety clip, all right, and we're going to release the valve with rapid pacing. So go ahead and pace again, please. 170. All right. Okay. Stop pacing, please. All right. So Saba, can you show us our valve?
You have to be careful
The valve
while
looks
removing
really
this delivery
well landed
system
on
so as not to
echo. There is
snag.
no paravalvular leak.
Okay. All right. So yeah, take your time, Saba. Tell us what you see. And I think it'll be great for us to see the physiology that you showed to us before the procedure, to see the pre and the post.
All right.
So
So here's your valve. You know, you're getting a very trivial central jet probably because you still have a very small catheter through the valve. There's no paravalvular leak. The valve looks well seated. This is a view of the valve on short axis. So I'm just gonna go towards the analyst to make sure we're not seeing any PV leak. And I think all we're seeing is that central AI. So we'll take the time to kind of look at the gradient of the valve. And with that, hopefully we'll be able to measure an aortic valve area. Since we already plugged
what I
in.
can tell you is I'm not feeling the pistol shot femorals anymore as I'm pressing on these.
So
the
based
arc.
on what I'm seeing now, the mean gradient is 6, and the valve area by continuity is 5.2.
Raj, I think this has been a phenomenal. Yeah, let's see your
So
hemodynamics.
look at the
So I think you
hemodynamics
can
now.
see the hemodynamics. So if you remember, I don't know if it's possible to show the pre and the post, but look where the aortic diastolic pressure is and where the LVED is. You've got a big difference now. And when we started, essentially, they were almost meeting each other, right? So, Saba,
Yes,
Saba is
and-
showing you the diastolic.
This is the descending thoracic aorta, and you can see now there is resolution of that whole diastolic flow reversal that we saw. So that kind of shows that the degree of regurgitation has improved significantly.
All right. So, as you saw, complete abolition of aortic regurgitation. You saw the mechanism of deployment. The hemodynamics are excellent, and you saw what the hemodynamics were, right? The aortic diastolic pressure and the LV diastolic pressure were practically meeting each other before the valve replacement, and you saw how they actually separated with the diastolic pressure going up and the LV end diastolic pressure going down. So, I think, the fact that you can use this system to anchor not only in the annulus but also in the leaflets, gives extra bit of assurance, right, in patients who have no calcium at all. I think so that's important. Also, the fact that the way the valve is designed and then the way the valve is deployed, leads to coronary commissural alignment. So I think that may have some advantages as well in terms of hemodynamics, but also in terms of coronary access and possibly future TAVR and TAVR. I think if there is any downside,
to the whole thing, I think as we are learning, in the early stages, what we were doing is we were actually deploying the valve a little bit lower. Now we are beginning to deploy the valve a little bit higher. So the pacemaker rates are there. About 17% is the pacemaker rate, when we did one of the interim analyses. But I think, as we get more comfortable and we release this a little bit higher, perhaps we can even make a further impact on it. So I think it's a very niche technology, for use in patients with aortic regurgitation. With valve areas that are almost like 3 centimeters, 2.5 to 3 centimeters, effective orifice areas, and gradients are more like low single digits, or generally like around 5, 6, 7 millimeters of mercury across the valve. The 180 patient Align AR study has already finished enrolling in the United States. We actually contributed 45 of those patients at Cedars-Sinai Medical Center. In addition, we had also done some cases in the very early part of the JenaValve. Now, what we are doing is we are starting what is called the Continued Access Program. So we will enroll patients on an ongoing basis with the similar entry criteria, and that data will also be submitted to the FDA. So I think before it becomes commercially available, I think it's about a year, but we'll get to use it as a part of the Continued Access Program. I think that is what concludes. Are there any questions?